Good morning. My name is Eugene Yang. I'm a cardiologist here at UW Medicine and a clinical associate professor, and I'm also the medical director of UW Medicine Eastside Specialty Center. Today I'd like to share with you an update on lipid management. These are my disclosures. And the objectives of this program are, one, to recognize the high-risk groups that warrant treatment with a statin. Two is to identify statin-related side effects and how to manage these patients. Three is to talk a little bit about when to use non-statin therapies. And then finally, to discuss the results of one of the large clinical trials with PCSK9 inhibitors. So the way I want to organize this talk is to discuss four cases. One that focuses on primary prevention, a second case that looks at secondary prevention, third, a case of a patient who has statin intolerance, and then finally, how to manage patients who are unable to achieve their LDL target, and then finally, a couple of take-home points. So let's start out with a case of primary prevention. So Mr. M is a 59-year-old black man who does not have a history of atherosclerotic cardiovascular disease. There's no history of hypertension, diabetes, and he doesn't smoke. And there's also no family history of premature coronary artery disease. You can see the patient's blood pressure is well controlled and beneath the current guidelines of less than 130/80. His BMI is in the overweight category at 28.9, and you can see his lipid profile. He has a slightly low HDL cholesterol, and his LDL cholesterol is mildly elevated at 139. So if we look at the current cardiovascular risk calculator, is his risk less than 5%? Is he in the 5 to 7.5% category? Is he 7.5 to 10%? Or does he have a greater than 10% risk of a cardiovascular event using the updated ACC-AHA guidelines? And in fact, he falls in a high risk category, which is above 7.5%. So here is the atherosclerotic cardiovascular disease risk estimator from the American College of Cardiology, and you can see highlighted here that his 10-year risk is 8.9% when we incorporate his specific lipid profile, his blood pressure, his age, and his race. In 2013, the ACC came out with a new lipid guideline that basically focused on trying to reduce cardiovascular risk by treating patients who have elevated cholesterol levels. In addition to focusing on pharmacologic management, there was a whole article that discussed adherence to a heart-healthy lifestyle, really as the foundation to reduce atherosclerotic cardiovascular risk. But they also identified four statin benefit groups, which we'll talk about. And then finally, they did discuss specific safety issues. So the four statin benefit groups are, number one, patients who have known atherosclerotic cardiovascular disease, meaning patients who've had heart attacks, unstable angina, strokes, TIAs, or peripheral vascular disease. The second group are those who likely have familial hyperlipidemia, where their LDL cholesterol levels are greater than 190 milligrams per deciliter. The third group are diabetic patients. And finally, using the risk calculator for patients who are between 40 to 75 years of age, if they have a 10-year risk calculation that is greater than 7.5%, these are patients for whom moderate or high-intensity statin therapy is indicated. So one of the key, I think, areas of concern were that when the new guidelines came out 4 years ago, there were no LDL targets. And the reason for that is that the randomized clinical trials that had been published to date did not specifically focus on trying to aim for a specific LDL level. And that the patients, the intensity of statin therapy is what is most important to reduce atherosclerotic cardiovascular disease risk. There were also concerns that there was undertreatment of patients with statin intensity or overtreatment with less well-documented treatments that are non-statin therapies where there was a lack of outcome data. And really what the guidelines focused on was using statin therapies as the mainstay of treatment because most of the non-statin treatments did not have strong clinical evidence of benefit in reducing cardiovascular risk. So what we do know is that there's a very strong relationship between the LDL cholesterol level and atherosclerotic cardiovascular disease. And we do know that statins are the most effective treatment to lower LDL cholesterol levels, with the exception of the new PCSK9 inhibitors. And what we can show based on this graph is that there's a clear linear relationship between the rates of atherosclerotic cardiovascular events and LDL cholesterol levels that are plotted here. And the rate of events are proportional to the level of LDL cholesterol lowering. So if we add some of the recent trials, the Improve It trial that added ezetimibe to simvastatin, and the more recent Fourier trial, which was with evolocumab, a PCSK9 inhibitor, you can see that event rates are related specifically to how low of an LDL cholesterol level is achieved in the clinical trials. So for this particular patient, if we plug in his specific numbers, you can see that the recommendation is that he should be treated with moderate to high intensity statin therapy. So how do we define low, moderate, or high intensity treatment? So low intensity treatment is a medication that lowers the LDL by less than 30%. Moderate intensity treatment lowers the LDL by 30 to 50%. And high intensity statin therapy lowers the LDL by greater than 50%. And this just highlights the differences in terms of the potency of the different statins that are currently available. And you can see the medications that are the most potent include high-dose atorvastatin and rosuvastatin. So one of the controversies that arose from the risk calculator that was created 4 years ago was whether there was an overestimation of cardiovascular risk. And you can see here that a fair number of articles came out with concerns about the risk calculator overestimating cardiovascular events. So let's look a little bit at the cardiovascular risk calculator, and as you can see that there was a few issues that arose specifically around the cohorts of patients that were used to create this risk calculator model. And one was that there needed to be inclusion of African Americans. The previous risk calculator tool was the Framingham risk calculator, which was a primarily white population. And secondly, there was a concern that they needed to add the additional endpoint of stroke, which was not used in the original risk calculator. Additionally, you can see that some of the other requirements for the model that was created was to have community or population-based cohorts, to include whites and African Americans at a minimum, long-term follow-up of at least 10 years, and to also look at sort of more contemporary risk factor trends and event rates, since those event rates have gone down over the years with improvements in our treatment of patients with atherosclerotic cardiovascular disease. So you can see here the cohorts that were used for developing the risk calculator. Additionally, they looked at only hard cardiovascular endpoints, including cardiovascular death, non-fatal heart attack, and non-fatal or fatal stroke. And they did test these models with internal and external validation and with other markers when possible, as I've outlined here. So what are some of the controversies? So one, the pros of the new model are one, that they did derive the new risk calculator from multiple and more diverse cohorts. Unfortunately, there were only sufficient numbers to really accurately estimate risk for whites and blacks, and not Hispanics and Asians. And they did include more clinically relevant endpoints, including stroke. Some of the cons were that there was no peer review evaluation prior to the incorporation of these guidelines. There's a lack of specific risk calculator for Asians and Hispanics, concerns about overestimation of risk, and finally that the threshold for where treatment was indicated was for patients who had a greater than 7.5% 10-year risk. The previous calculator defined high-risk patients as those who had a 20% or greater 10-year risk using the Framingham risk model. So this significantly shifted down that threshold. So what are some of the I think outlying issues that have not been addressed by the new risk calculator? Are one, how to incorporate family history of premature heart disease, patients who have a long-term elevated increased risk of atherosclerotic cardiovascular disease, patients who have LDL cholesterols that are high but not very high, meaning their LDL cholesterol is between 160 to 190. What to do with patients who have a high sensitivity CRP level of greater than 2, patients who've undergone calcium scoring where their Agatston score is greater than 300, or if they have evidence of peripheral vascular disease with an ABI of less than 0.9. I think the most important point is highlighted at the bottom, which is that ultimately this requires, I think, discussion between the patient and provider and shared decision making about whether to initiate aggressive therapy or not when some of these additional factors may come into play, such as a strong family history of premature cardiovascular disease. So if you look at some of the studies, a recent Kaiser Permanente study looked at the rates of cardiovascular events in their cohort of patients, and you can see that if you look at the expected rates of events versus the actual rates, you can see in the Kaiser population that they were significantly lower in non-diabetic as well as diabetic patients, as highlighted in the blue columns. So this is one example of where there have been some concerns about overestimation of risk. Now, admittedly, the Kaiser Permanente study is a very specific population. There's clearly some selection bias, and so we have to take that into consideration when reviewing the differences between the observed rates versus the estimated rates of events based on the risk calculator. On the other hand, another study called the REGARDS trial, you can see there was better alignment between the predicted versus the observed risks. So the observed risks in the red columns again, I think more closely aligned with those predicted by the new 10-year cardiovascular risk calculator. One of the recent 2013 Cochrane surveys for statins for primary prevention, I think it is important to acknowledge that with the update just about 4 years ago, that you can see that when adding some new clinical trials, that the all-cause mortality rates, the odds ratio was 0.86 for fatal and non-fatal cardiovascular disease. The relative risk was 0.73. Rates of revascularization, the relative risk was 0.62. So there's clearly a strong benefit in both all-cause mortality as well as fatal and non-fatal cardiovascular events and for primary prevention, which is an area that has been, I think, most controversial with respect to treatment of patients with statins. The U.S. Preventative Task Force statin use update came out about a year ago, and they reviewed 19 randomized clinical trials of patients between 40 to 75. They did exclude the high-risk groups, those who had known atherosclerotic cardiovascular disease and those who had an LDL levels of greater than 190. And you can see that for patients who had one risk factor and a 10-year risk using the new calculator of greater than 10%, that all-cause mortality was reduced by 14%, cardiovascular mortality was reduced by 31%, heart attack and composite cardiovascular outcomes were reduced by 36 and 30% respectively, and you can see the number needed to treat for those two outcomes was only 72. So these numbers are certainly not spectacular, but given the fact that we're talking about treating patients at a population-based level, these translate into potentially hundreds of thousands or millions of people with fewer events as a result of treatment in primary prevention. The U.S. Preventative Task Force statin recommendations slightly differ from the cardiology guidelines in that they recommend low to moderate intensity statin therapy for patients with no known cardiovascular disease with 1+ risk factors and a 10-year risk greater than 10%. And it gets a level B recommendation with high level of certainty of at least a moderate benefit. And you can see that there is less certainty and less benefit associated with patients with a risk of 7.5 to 10%, and those over 75, they have insufficient evidence. So what do we do about this patient? I think the key thing is not to jump immediately into treating this patient with medication, but to work on lifestyle changes. This patient's BMI is in the overweight category, so certainly diet and exercise to try to make improvements in both the HDL cholesterol, lowering the LDL cholesterol, even having some additional benefit on getting the patient's blood pressure closer to optimal range, which is less than 120 over 80, is I think what I would do for this particular patient, and then repeat his fasting lipid profile in 3 to 6 months and see if there are improvements. On the other hand, based on the current guidelines, it is not unreasonable to also talk about treatment. Depending upon which set of guidelines you use, whether it's U.S. Preventative Task Force or the ACC-AHA guidelines, you could discuss low to high intensity statin therapy to try to optimize his lipid profile. So let's go to case 2, which is a secondary prevention case. So Mr. D is a 66-year-old man. This patient is in fact my patient, who has a history of coronary artery disease, had a non-ST elevation myocardial infarction with PCI to his obtuse marginal in 2002, has hypertension, hyperlipidemia, and has a history of an abdominal aortic aneurysm, who presented to me for management of his coronary artery disease. Fortunately, has not had any recurrence of symptoms, and you can see that his medications include aspirin and low-dose lisinopril. His blood pressure is well controlled at 123/68. His BMI is slightly in the overweight category at 25.9, and you can see his lipids are quite abnormal, with a total cholesterol of 269, an LDL that's very high at 204, and he has evidence of borderline prediabetes with a hemoglobin A1C of 5.7%. So if we look at the current guidelines, the recommendations are: 1, to not treat him with a statin; 2 is to add niacin for low HDL cholesterol; 3 is to start low-intensity statin therapy; and 4 is to choose a moderate or high-intensity statin. And based on the current guidelines, the recommendation for this high-risk patient is moderate or high-intensity statin treatment. So as the guidelines have outlined, atherosclerotic cardiovascular disease is defined as patients who have had an acute coronary syndrome, history of myocardial infarction, stable or unstable angina, coronary or other arterial revascularization, TIA, stroke, or peripheral vascular disease. And so for a patient who's less than 75 years of age, high-intensity statin therapy is recommended, or moderate-intensity statin therapy if they're not a candidate for high-intensity treatment. And then finally, for patients over 75, either moderate-intensity statin therapy or patients who are not candidates for high-intensity treatment. So this one study is probably one of the most pivotal trials that came out many years ago in the early 90s, the 4S trial, which was a Scandinavian study. And I just highlight this study to show the benefit of statins and secondary prevention. So you can see here that at 5.5 years of follow-up, that all-cause mortality was reduced from 12% to 8%, and there was an overall 42% reduction in cardiovascular mortality. So in secondary prevention, I think there's clearly less controversy about the benefits of statin therapy, and this trial certainly highlights the benefit of treating these high-risk patients. So in this patient, the question is, what is the optimal treatment? And I think it's a little bit simpler. For this patient, I think high-intensity treatment with atorvastatin 40 milligrams a day or rosuvastatin 20 milligrams a day would be appropriate. The patient's fasting lipid profile should be checked 1 to 3 months after initiation of treatment. And if the patient achieves a greater than 50% reduction in his LDL cholesterol, then monitoring should occur every 3 to 12 months. If the patient, however, does not achieve a greater than 50% reduction in his LDL cholesterol, then his atorvastatin could be increased to 80 milligrams a day, or ezetimibe 10 milligrams a day could be added to try to achieve a greater than 50% reduction from his baseline LDL cholesterol. One of the things that has come up frequently in my conversations and presentations regarding lipid management is what to do about monitoring of patients once they're started on therapy. And many, I think, have not reviewed the guidelines thoroughly enough to realize that there is recommendation to routinely monitor lipids to assess response to therapy and adherence. And so if you look at the current guidelines, to not only monitor whether there is the appropriate reduction in LDL, but also determine whether there is adherence. When patients are started on statin therapy, they should have a fasting lipid profile performed within 1 to 3 months after initiation or dosage adjustment. And once the patients are stabilized on therapy, then monitoring should occur every 3 to 12 months thereafter. Other safety measurements such as liver function tests or CPK levels should be measured as clinically indicated. For my own patients, I probably, once they're stabilized, monitor their lipid profile every 6 to 12 months. So let's talk about statin intolerance, which certainly is something that comes up very frequently in clinical practice. So this same patient calls my office after we have started him on atorvastatin 40 milligrams a day, and he's feeling generalized aches in his muscles since starting the medication. You check appropriately his CPK level to look for evidence of myositis or rhabdomyolysis, and his CPK level is normal, and that's pretty frequently the case. The patients will not have elevations of the CPK levels indicating myositis. More often, the patients just suffer from myalgias or generalized muscle aches. So here are his current medications. So the question is, what do we do next? So the first is, don't worry, it isn't the statin. You wouldn't change the dosage of his medication. Option 2 would be to stop the medication for 2 weeks and see if his symptoms improve. 3 would be to try to lower the dose of his atorvastatin 40 to 20 milligrams a day to see if his muscle aches improve. And then finally, do you stop the medication and try a different statin, rosuvastatin 10 milligrams a day? And I think the options are any of the 3 outlined in red below. I think that the idea that it isn't the statin is certainly possible, but I think we can't really draw that conclusion since there seems to be a clear temporal relationship between the onset of his symptoms and the initiation of his treatment. So let's talk about statin-related side effects. So the most common are muscle-related side effects. Diabetes, which we'll talk about, cognitive impairment, liver function test abnormalities. Certainly the muscle-related side effects in clinical practice probably occur 5 to 10% of patients. So looking at it from a different perspective, that tells us that 90 to 95% of our patients, or 1 to 10 or 1 in 20 of patients, will experience these side effects. So most of the patients will actually not have any of these side effects when taking a statin. So again, if we look at muscle-related side effects, myalgias, which are only pain-related symptoms without CPK elevations, have occurred in about 5% of randomized clinical trials. In real-world experience, I think that's probably up to 10% of patients. Myositis, you can see, is very rare, only occurring in 5 in 1,000 patients, and rhabdomyolysis is very uncommon, only occurring in 1 case per 10 million prescriptions. And those who are at highest risk are those who are taking concomitant therapies such as niacin, gemfibrozil, or cyclosporin. There's also an increased risk in patients who take high-dose simvastatin 80 milligrams a day, especially when they're taking other drugs that affect the metabolism of simvastatin. And that was reflected in the update by the FDA in 2011, where the highest dose recommended was 40 milligrams a day unless the patients had been on simvastatin 80 milligrams a day for a year or longer without associated side effects. So let's talk about statins and diabetes risk. So there has been a lot of concern about some association between statins and diabetes risk, primarily based on observational studies, not based on randomized prospective clinical trials. A meta-analysis of 13 trials that was published a few years ago found about a 9% relative increased risk of developing diabetes. If you look at the absolute risk between those who were on statins versus those who were not, you can see the number needed to harm was 256, meaning that for every patient that had developed diabetes, 255 patients did not develop diabetes who were treated. Older subjects seemed to be at higher risk, and it did appear to be a class effect. However, the conclusion drawn from that study was that the slightly higher risk of diabetes is certainly outweighed by the greater cardiovascular benefit in those who are appropriately treated with a statin. So if we go back to the 4S trial and we look at the number needed to treat to prevent one event, the number needed to treat in that trial was 25 to have one lower rate of lower cardiovascular event. So if you have 250 people, you have one incident case of diabetes, and you have potentially 10 people who do not have heart attacks. So clearly the benefits of treatment in that particular case outweigh the risks of developing diabetes. I think another key point is that if you look at the recent U.S. Preventative Task Force analysis, there was no associated increase in diabetes risk from their recent analysis published in 2016. Statins and cognitive impairment is definitely another area of concern. There's certainly anecdotal reports of memory loss with some observational data that's been published. Additionally, the FDA did come up with some concerns a few years ago suggesting a potential association between statins and cognitive impairment, although most of these are not based, again, on large randomized clinical trial data. And in fact, there's probably more evidence that statins may reduce the risk of developing dementia or, in fact, slowing the progression of dementia. There may be a relationship between the lipophilicity of the statin, that is, drugs that are more likely to cross the blood-brain barrier, and cognitive side effects. And then finally, the U.S. Preventative Task Force analysis, in addition to not finding association between statins and diabetes, did not find an association between statin use and cognitive impairment. I think another important study that recently was published a few months ago was the Ebbinghaus study. The Ebbinghaus study was a sub-study of the Fourier trial, which was a large randomized clinical trial of patients randomized to evolocumab, a PCSK9 inhibitor, versus placebo for those who are already taking statin therapy for secondary prevention. And because of the concerns about an association between aggressive cholesterol lowering and cognitive function, this study was conducted. And essentially the results of this study showed that there was no clear association between patients who are aggressively treated with evolocumab versus placebo in terms of primary cognitive endpoints. Finally, let's talk about statins and liver disease. As you can see, that there's a very low rate of LFT elevations, meaning typically defined as elevations 3 times the upper limit of normal. You can see that occurs generally in about 0.5 to 3% of patients. Liver failure is very uncommon and idiosyncratic. And you can see that the FDA did not specifically recommend baseline liver function tests or monitoring because the incidence of LFT elevation is very low. And more importantly, even patients who have chronic liver disease, they can still be treated with statin therapy safely. So how do we manage patients who have statin intolerance? Number one, we need to review their comorbidities, in particular their medication list. So medications that interfere or interact with the CYP3A4 P450 system enzyme is important because that can either increase or decrease the levels of statins, since many of them metabolize to this particular cytochrome. 2 is to stop and re-challenge the patient. So typically in clinical practice, I'll have the patient stop the treatment for at least several weeks to see if there's any improvement in their muscle symptoms typically. And if there is no improvement, then typically I re-challenge them, since there's no clear change associated with stopping the medication. Another option is to try a lower dose. So if the patient is taking 20 milligrams or 40 milligrams of atorvastatin, then I will halve the dose and see if the muscle symptoms are mitigated. Other possibilities are to choose more hydrophilic statins, which we'll talk about, such as pravastatin or rosuvastatin, versus the more lipophilic statins, which include simvastatin or atorvastatin. There is another statin called pitavastatin, which is also available, which is primarily metabolized through glucuronidation of the liver and has a non-CYP3A4 metabolism. And I've found in clinical practice that some patients are able to tolerate this better than statins that are metabolized through the cytochrome P450 system. Finally, there is an ACC statin intolerance tool that I've highlighted here. Unfortunately, it is not very user-friendly, as a lot of data points need to be entered, and so I haven't found it to be that clinically useful, but for those who are interested, it's listed here. So let's talk about the lipophilicity versus hydrophilicity of statins. So in general, the more lipophilic statins are the ones that do tend to have more of the muscle-related side effects. So simvastatin notoriously does seem to have more myalgias associated with it, whereas rosuvastatin and pravastatin, which are more hydrophilic, tend to have fewer muscle-related side effects. As you can see, the lipophilic statins are more likely to penetrate non-hepatic tissues such as muscle and brain. So if you have patients who have myalgias of cognitive changes, then I will try a more hydrophilic statin. Typically, I try pravastatin first to see if patients tolerate that medication, and use a low dose, let's say 10 milligrams a day, and titrate it up to try to achieve more aggressive lipid lowering. So for this particular patient, I think one strategy would be to stop the atorvastatin for 2 weeks and see if the muscle aches improve. If no improvement, then I would restart the medication. If the symptoms do resolve, then we could re-challenge the patient with a lower dose. So instead of 40 milligrams, put them on 20 milligrams of atorvastatin a day, or try alternate dosing, such as having the patient take it every other day. Or the other possibility is to try a more hydrophilic statin, such as rosuvastatin. In this particular case, since this patient is very high risk and has a very high LDL cholesterol level, pravastatin, being a more moderate intensity statin, is not likely to achieve the kind of LDL reduction that we are trying to look for in this patient. So what do we do about patients where we're not able to achieve their LDL target? So Mr. D comes back to clinic, and so over many months he was re-challenged with a lower dose but had the same symptoms, and then was tried on, you can see here, multiple statins, including rosuvastatin, pravastatin, lovastatin, and ezetimibe, and had the same muscle-related side effects that were really debilitating for him. So based on these recommendations, results, what do we do? So one would be to re-challenge the patient with a different statin, such as pitavastatin. Two would be to try a PCSK9 inhibitor. So there are two currently commercially available, alirocumab and evolocumab. And three is to re-challenge the patient and try non-pharmacologic therapies such as plant sterols or red yeast rice. So in my opinion, I think the opportunities, one would be to try a different statin, pitavastatin, which, as I said before, is metabolized through a non-CYP3A4 mechanism, or two, to try PCSK9 inhibitors. I think that the last option is probably, in this patient's case, who's had a heart attack and who has very high LDL cholesterol levels, I think there's still other ways to try to manage this, and so I would not use those non-pharmacologic therapies for this particular patient at this time. So the non-statin therapies, there are several that are currently recommended by the ACC and the AHA. There was just an update published in the last few months to the expert consensus decision pathway for non-statin therapies for LDL cholesterol lowering. And so the questions that were being addressed in this particular pathway are: one, what are the populations where non-statin therapy should be considered? Two, what situations should non-statin therapies be considered in? And in what non-statin therapy should be initiated and in what order? So in the updated guidelines that came out a few weeks ago, the opportunities are to use these non-statin therapies specifically in very high-risk patients, meaning those who have known atherosclerotic cardiovascular disease, like this patient who had a heart attack, or those who have very high LDL cholesterols where there's likely a familial or genetic cause. And if they're unable to achieve a greater than 50% reduction in their LDL cholesterol from baseline, either because they're on treatment and don't achieve a goal, or because they have intolerances where they can't take any of these therapies, they finally did come up with a specific target in this population to try to achieve an LDL cholesterol level below 70 or non-HDL cholesterol level of below 100 in these high-risk patients. And that stems from some of the recent clinical trials where an LDL target was specifically addressed, which we'll talk about in the 4EA trial. If there's a less than 25% additional LDL lowering requirement, then ezetimibe should be considered first. If patients need more LDL lowering of greater than 25%, then a PCSK9 inhibitor, either alirocumab or evolocumab, may be preferred. So let's talk a little bit about the 4EA trial, which was the first secondary prevention PCSK9 outcome study that has been published. And it was a very large randomized trial of over 27,000 patients who had known atherosclerotic cardiovascular disease. More than 80% of the patients had a history of a heart attack, and they had to have an LDL level at baseline of greater than 70 on maximally tolerated statins. So you can see that almost 100% of the patients were on statins, and about 5% were also on adjunctive therapy with ezetimibe. And they were randomized to statin plus a placebo injection versus statin plus evolocumab, either twice a month versus once a month injections. And the primary endpoint was cardiovascular death, heart attack, stroke, ACS hospitalization or coronary revascularization. And the secondary endpoint was cardiovascular death, heart attack, and stroke. And then there were safety endpoints. We talked about the neurocognitive sub-study, and then injection site reactions, LFT abnormalities, myalgias, and diabetes. So what you can see here is that you get a very dramatic reduction in LDL cholesterol levels between the placebo and the treatment arm within a very short period of time. So within a month, you can see there's a 60% reduction in LDL cholesterol levels that's sustained over the course of the trial, as outlined here. If we look at cardiovascular events, if you look at the primary efficacy endpoint and the secondary efficacy endpoint, you can see that the number needed to treat was 50, and the absolute risk reduction at about 3 years was 2%. The overall risk reduction was only about 15%, which certainly was not quite as robust as people had anticipated, but certainly showed at a shorter period of time there was a benefit. If we compare this to the IMPROVE-IT trial, which was a study of ezetimibe plus simvastatin in high-risk patients, those who had a heart attack, it took 7 years to see a 2% absolute risk reduction. So in this study, over a much shorter period of time, you can see that there was a separation between those who were treated with evolocumab versus those who received placebo. So if we look at the results, the median LDL cholesterol level achieved in the evolocumab group was very low at 30 milligrams per deciliter at less than a year. Again, there was some concern that the overall relative risk reduction was only 15% at 3 years. Some have argued that if the study had been extended longer, that separation would have been greater, and the relative risk reduction as well as the absolute risk reduction would have been even more significant. I think one of the other concerns was that there was no reduction in all-cause or cardiovascular mortality, but there was about a 20 to 27% lower risk of stroke, heart attack, and coronary revascularization. There were no major safety issues with the exception of more injection site reactions. I think one of the key concerns is related to the cost. So the cost of the drug is approximately $14,000 a year, and a recent study argued that in order from a cost-benefit standpoint for the drug to provide an appropriate benefit, the cost of the drug would have to be lower to about $4,500 a year. Alirocumab, which is the other PCSK9 inhibitor that is currently in clinical trials, its large outcome study called the Odyssey Outcomes Trial is going to be presented at the large cardiology meeting, the ACC 2018 in March in Orlando. And that hopefully will provide us with some additional insights in terms of the benefit of this particular treatment. So for this particular patient, he was actually started on alirocumab, 75 milligrams twice a month. Fortunately, he did not have the same myalgias and muscle aches associated with it and has been able to tolerate this medication since we started it last year. And as you can see from his baseline LDL cholesterol level, which was 269, and a LDL of 204, his most recent lipid profile in August, his total cholesterol was down to 129, and his LDL was down to 57. So based on the current guidelines, you can see that his LDL is below 70, which is our current target for these high-risk patients, and this patient has been able to achieve that with the alirocumab. So the take-home points for this presentation are, one, that currently statins are the primary treatment for lipid-lowering therapy for most of our patients. We have a new 10-year risk calculator that was published about 4 years ago, which is certainly better and reflects a broader population, but still may have challenges with respect to overestimating risk. Statins have been demonstrated to reduce cardiovascular events in both primary and secondary prevention studies. Clearly, the evidence and data is not quite as strong for primary prevention as it is for secondary prevention. I think one of the things that has certainly come up in clinical practice is that people tend to be quick to give up on statin therapy and go to alternative treatments as opposed to making either adjustments to the dosage of the medication or do statin-free trials in re-challenging patients. And I think that is one of the key messages, is that we should try to be more aggressive at trying alternative statins. For example, those treatments that are potentially hydrophilic versus lipophilic. And in many cases, the patients tolerate those medications better. And then finally, statin therapies such as ezetimibe or PCSK9 inhibitors should be used in specific high-risk populations when patients are unable to achieve LDL targets, or in some cases where they're completely statin intolerant and in a very high-risk group of patients. These drugs are certainly indicated based on the recent clinical trial data that shows a potential cardiovascular benefit. So with that, I will conclude, and I thank you for your attention to this presentation. My email address is listed below, so please feel free to email me anytime with questions around this presentation. Thank you.